Transvaginal sonography has an important role in the evaluation of endometrial disorders. One has to be very careful to image in scan planes that are relative to the endometrium and look at the endometrium in some cases using sonohysterography. So I've shown you where the role of transvaginal sonography in patients with postmenopausal bleeding is to decide which patients need endometrial biopsy. Now, sometimes this patient, after showing a 2 millimeter endometrium, underwent endometrial biopsy because the clinician was insistent and the tissue came back insufficient for diagnosis. In a meta-analysis by Smith-Beinman, she showed that when the endometrium was less than 5 millimeters and the patient had no real risk factors for endometrial carcinoma, this basically excludes the possibility of endometrial cancer. And this finding did not vary in patients who underwent hormone replacement. So, in other words, transvaginal sonography is an excellent means to screen patients for endometrial carcinoma. Unfortunately, there's a high level of operator dependency of transvaginal sonography, but I think if you use 6 millimeters as your general guideline for which patients need biopsy, which patients can be followed up, that is very helpful. I want to mention briefly the use of color Doppler in endometrial disorders. The endometrium is supplied by vessels coming from the arcuate, the radial vessels that come into the endometrium by the spiral vessels, and there are some basal layer vessels. But in patients with polyps, typically the spiral vessel is enlarged. Here's a color Doppler showing the radial vessels. As you can see histologically, we find a few small vessels in the endometrial layer. These represent the spiral layer, spiral vessels, as shown on this image of the histology. These are the glandular elements. As I mentioned, most polyps will drag a feeding vessel into them. In fact, it makes it very clear that this is a polyp, for example, that has a big vascular pedicle. This is a big polyp with multiple vessels, as opposed to a patient with hematometria that has little or no vessels within the center. This is a patient who had infertility. The polyp is shown here with its feeding vessel. This is a patient that had fluid. We did not instill fluid. She presented with this amount of fluid in the lumen. These polyps are very irregular, and as you can see, some of the large feeding vessels is shown here. This is the hysteroscopic picture of these polyps that were found to be endometrial carcinoma. I want to mention briefly the use of transrectal sonography and specifically biplane transrectal sonography for difficult patients that may have cervical stenosis. These probes have a linear array here and an axial orientation of the transducers at the top. And a condom is put over the probe, and the probe is introduced transrectally. And as you can see, the field of view is very limited to the cervix and part of the uterus, but it's very helpful. For example, here's a patient that on transvaginal sonography has an echogenic area in the myometrium. These are 2 or 4 images from a transrectal, where this is posterior, this is anterior, this is inferior, this is superior. And we could help guide the gynecologist in putting the dilator right into the area of the cervix. And finally, you can see its location within the lumen is very clear. This is a patient with a very abnormal cervix. The dilator is going too posteriorly, and when corrected, went in beautifully. So here's the dilator going into the cervix, and we could see that it's in the proper position. The retractors have to be out toward the side to get a good image. Now the actual curettage instrument is being introduced. We could confirm that it is luminal by activating the axially oriented transducer. So we're going to do that and see. So now this is posterior, right, left, and we're moving the probe, and here will be the uterus. Right here, this echogenic area is the dilator, and we could confirm that we're indeed in the lumen of this uterus. Now we're back in long axis. The curettage instrument is now obtaining the endometrial tissue. And I highly recommend this technique in the difficult patient. Here's a patient that unfortunately the bladder was not distended enough. This is the uterus, and the dilator could be seen going right through the uterus into a bowel loop, and when we corrected for a non-distended bladder, we got into the uterus perfectly. So what I've tried to do in this review is to show you that transrectal and transvaginal sonography has a very important role in evaluating patients with endometrial disorders. It's very important that one gets the entire endometrium either manually or by 3D, and understand the endometrial disorders are different in premenopausal and perimenopausal women as compared to postmenopausal women, where one is thinking about endometrial cancer. Hyperplasia and cancer can be diagnosed, and one can use sonohysterography for further evaluation. Thank you.